Hello, and welcome to the Two View, the cutting-edge educational interactive show for nurse practitioners and PAs in emergency medicine and urgent care. My name is PA Michael Sharma, and I practice emergency medicine and urgent care in Dallas, Texas.
And I am an exhausted Martha Roberts, NP. Good to see you, Mike. And I'm getting off 3 12-hour weekend nights at the San Francisco General Trauma Center. And I just hope I can make it through the show today.
I think we're going to make it okay. I'm also kind of recovering from a little post-Memorial Day fun. I hung out with my friend Nate and his family. Shout out to Nate. I'd like to bring him on the show sometime. He has a very particular set of skills that I think would be a cool thing to talk about on our podcast, to look and be aware of kind of like chem bio stuff and what to look for that thing in case we have sort of a mass cal event outside of your ER. Something else we're both kind of revving up for is our emergency medicine boot camps. And so we have our original boot camp coming up. It's going to be July 26 and 27. We have a pre-course pharmacology and ultrasound courses. I know a lot of nurse practitioners really need those pharmacology hours, and you'll get some great hours and great instruction from Michael Gooch, NP extraordinaire. He's been doing those pharmacology workshops with us for a long time. The main course is from July 28th through 31st. The Katy Perry concert, July 29th, in case you're interested in that. Katy, free admission to the boot camp. I know you're listening. Come on down and hang out with some healthcare heroes. August is our advanced boot camp, and then we're going to do a pre-course EKG and procedure workups there, and then running the original boot camp back again in December. Great Christmas gift for you and a PA or NP that you might work with. Anyways, we're keeping it light, folks. It's a summer day. I've got good natural light coming through the windows here. Let's start off by bringing you what you need to know about monkeypox, including why we as PAs and NPs might be more likely to see this than our physician colleagues. There's also some ways you're going to want to change your practice regarding this outbreak. But out of the gate, I just want to reassure everyone that if there is a massive monkeypox outbreak and we all get monkeypox, I'll be okay.
Hold on. Don't you mean we'll probably be okay?
I mean, like probably, but for sure, I'll be okay. I'll explain in a second. After that, Martha is going to talk some tips from the heart about a typical busy day in the ER for an NP or PA, and what her kind of strategy is for siphoning through a bolus of patients that come all at the same time.
And then finally, Mike is going to talk about 3 evidence-based tactics you can use on your next busy shift when patients are piling up. So we've got a lot of things that will help you run right away on your shift. There are a bunch of things that will save you time. These are some common time-consuming workups and interventions we're going to discuss. Mike's also going to mention an opportunity for you to get even more tactics from him for free.
Free.
I'll end on a note about a case on an allergic reaction to give or not to give epinephrine.
Okay, I had to give epi. I've been giving it a lot recently. I don't know what's going on here. I'm seeing
little Oprah epi there. Everybody
gets You get epi. You get epi. Everybody gets epi. Sadly enough, I've given more epi in this past year than I have in my entire EM career. I feel like I don't know if it's just me being more sensitive to possible anaphylaxis or scared. I mean, I don't know. We'll talk about that at the end. As I was wrapping up my PD hepatitis segment on the last episode, I was not thinking I'd be discussing another unusual disease outbreak on this episode, but here we are. Let's talk monkeypox and how you should be changing your practice while this outbreak, or whatever you want to call it, is going on. Now, monkeypox is an endemic viral illness in parts of Africa. It's there kind of like all year round. It's been a known thing since 1970, before I was born. So why is monkeypox getting so much press now? What's different now is that usually the rare person with monkeypox reports some sort of recent travel to an endemic area. That all changed in May 2022 when multiple people on multiple continents, including here in North America, have been diagnosed with monkeypox with no recent travel to Africa, and it's unclear why.
Yeah, so on May 20th, 2022, the CDC put out a health alert advisory and about a cluster of monkeypox cases in the United Kingdom. As always, we will have this link to the CDC health advisory and every other reference we discuss on our website. And that, by the way, is 2view.fireside.fm. And that's the number 2, view.fireside.fm. I thought that some of their guidance was very specific and really pertinent to us as NPs and PAs. They said clinicians should be especially suspicious of a rash that looked like a typical monkeypox rash in patients who, and I quote, 1, travel to countries with recently confirmed cases of monkeypox, 2, report having had contact with a person or people who have had similar appearing rash or received a diagnosis of confirmed or suspected monkeypox, or number 3, and again, I'm quoting here directly from the health advisory, is a man who regularly has close or intimate in-person contact with other men, including those met through an online website, digital application app, or at a bar or party.
Yeah, that's pretty specific. I agree that maybe PAs and NPs need to be more on their game about monkeypox than anyone else in the ED or urgent care. And here's why. The patients of one of these early clusters reported on in the health advisory presented to a sexual health clinic, for a concern for STDs. When someone checks into the emergency department for a genital rash and they want to get checked for an STD, that's going to be a level 4 or 5 ESI, and those cases usually fall to the PA or the nurse practitioner on duty. The health advisory mentions that these lesions can be confused for other more common rashes, like herpes simplex, secondary syphilis, and zoster. Martha and I are not at all intending to shame or stigmatize any individual or any community, but both the CDC and the World Health Organization, the WHO, are making a very specific note of how there seems to be a cluster of infections in the broad communities of, and now I'm quoting from a WHO press release, quote, gay, bisexual, and other men who have sex with men. Transgender people and gender diverse people may also be more vulnerable in the context of the current outbreak, end quote.
Yeah. So, Mike, I laughed at the verbiage.
No, I know. It's just, you're not making fun.
I'm just making sure that our audience understands this. I mean, seriously, a bar or a party. Well, why not the mall or a grocery store? That's why I laughed.
It's weirdly specific, right? Like
what the heck?
Using an app, like meeting someone through a digital app, like it's just a very peculiar verbiage. I agree.
I met them through Bumble and not eHarmony, so I should be okay, right?
Exactly. Oh my gosh.
Anyway, that's why I laughed, just to make sure, because it's just so ridiculous. But I don't know if I understand it or not. But anyway, moving on. Monkeypox, however, is not an STD, and we're here on the podcast, and both the CDC, us here on the podcast and the CDC and the WHO want to make it clear that anyone can contract this infection, anyone, and sexual intercourse is not required for transmission. It's thought to be spread by droplet and direct contact with body fluids, lesions, and even fomites. Speaking of rash lesions, this is how you're going to spot it. The classic rash starts out as an erythematous macule and papule, so red spots and bumps that progress to clear vesicles and later pustules. What classically differentiates most monkeypox from other similar vesicular rashes is that the lesions in a body region are usually all the same stage of development. So if someone has a rash on their arm, all the lesions on their arm will likely be roughly the same size and be the same stage of development, whether that's a macula, papule, vesicle, or pustule.
Yeah, that's different from the classic description of chickenpox, let's say, where you can have lesions in different stages of development. You'll have a macule here and a clear vesicle here and a crusted over pustule there. I think it's great you qualified your statements with classically. Like usually the patients with monkeypox have a 2-day prodrome with a flu-like illness. Usually there is lymphadenopathy. It's another interesting tip there is lymphadenopathy. Usually these grouped lesions on the same part of the body are in a similar stage of development, but it's not mandatory. So don't be fooled when you see a patient that might be affected by monkeypox, but they don't fit every single textbook feature of the disease. Keep an open mind, wear your PPE, and strongly consider testing these suspicious lesions. So how do you test? This is a DNA virus. but the CDC is not recommending that you put them in your typical viral media like you might to confirm like herpes simplex. They give very specific directions about who to contact and how to swab and transport these samples. I won't go into them here, but they are on the CDC Health Advisory. Check it out at our show notes at twoview.fireside.fm if you think you have a case in front of you.
So let's talk about how to change your practice temporarily. First, it's being aware of this disease, that it can be out there, and letting it be a part of your differential when you care for a patient who is having an acute flu-like illness, fever or not. Is it just a regular cold? Is it COVID-19? Is it influenza? Is it strep? Is it mono? Both of these have lymphadenopathy. Or is it monkeypox? It's going to be tough to distinguish them from every other on day 1 or 2 of symptoms. Even shingles can have a little prodrome flu-like illness before the rash shows up. Next, I think it's asking patients if anyone, if they've been in close contact with anyone who has the illness. If nothing else, you can document that they have no known close contacts with the known illness.
Yeah, or any illness. I'm still a little shook after reading about a malpractice case that was brought up at a talk during the recent AAPA National Convention. Thank you, by the way, to Indianapolis for hosting the AAPA. I heard it was a real banger, and I'm looking forward to being there. I think it's in Nashville next year, so looking forward to being there. She presented to an urgent care clinic, this other patient in this talk with flu-like symptoms. A PA diagnosed her with a URI, gave her azithromycin just in case. Not a fan of that tactic in a young person, by the way. And the patient went on to bounce back to a hospital in respiratory distress and get admitted and die from influenza and MRSA pneumonia. What was not uncovered in the patient's the PA's history taking, was that the patient's father was admitted from his nursing home to the hospital for MRSA 2 days before the patient went to the urgent care. I've got a link about this case in the show's notes. Look, I'm not sure if I would have cracked the code on that one if I were in that PA shoes. It's just a gentle reminder of the weirdness that is medicine.
Yeah, that really sucks. What we can do is ask more questions. Always, it never hurts to ask more questions. I also, Mike, we talk about other clinical pearls and tips of sort of like putting your own spin on things. This sounds kind of silly, but I like to ask patients like, what do you think is going on? Like,
Yes.
What do you think caused this? And that's sometimes when they say like, oh, well, actually I did this, or this person was sick, or I remember. It may not seem important. So what can make monkeypox tricky is that there can be a long incubation period, 2 to 3 weeks. So someone coming to see you may have no idea that someone they met weeks ago is now ill. But again, at least you asked and you can document that you did a thorough history. And if nothing else, it's better protection for you. One last thing we can do, Mike, is I know you will examine this rash sometimes without gloves. I think it's time to glove up, dude. I mean,
well, not every rash, but yes, I am totally gloving up for rashes from here on out. I'm not taking my bare hand and like pushing on obvious like cellulitis or abscesses, but like sometimes you get these like viral exanthem looking rashes and like a pediatric patient with URI. I'm not usually concerned about catching whatever virus patients have just by touching their exanthem is what I'm checking for like blanching. But now my concern has gone up a little bit. The CDC suggests that people may be contagious in their prodrome, so that kind of flu-like illness for 2 days, but they are contagious by the time any rash appears until when all the lesions have crusted over and the crusts have fallen off. That can take 2 or 3 weeks, a very long contagious period. What's reassuring for me is at least I'm vaccinated against smallpox. Before I went over to Iraq, I got vaccinated against smallpox in the Army because of the concern that it was going to be used as a biological weapon. This smallpox vaccine does seem to confer good protection. The number I saw was something in like the 85% range. And that's nice when the CDC is estimating mortality from monkeypox somewhere between 1 and 11%. That's kind of a wide range. I don't know if I like the top end of that range.
This is a developing story for sure. It went from 1 US case on May 17th to 12 cases in multiple states 10 days later. With this long infectious period and long incubation stage, these numbers are going to rise. So keep your eyes open for new developments, keep your differential diagnosis wide, and keep your hands gloved. Also, I keep thinking like, I don't want a new disease to come out, and I don't particularly want to be the one to name it, but I keep thinking like, what would I name my new disease? And I've decided that if I could name any disease, I would just call it Nana Boo Boo disease. That's what
And
I've
then,
decided.
I mean, it's not any worse than chikungunya.
Okay. Anyway, by the way, Nana Boo Boo is still like a thing. I had some kids over yesterday afternoon and they're still saying Nana Boo Boo. Like, what? That's like still a thing for kids.
You
I'm
know,
like,
the
come
old
on.
classics die hard, you know?
Yeah, really. All right. On to segment 2. This segment, Mike, it's going to come from the heart and from experience. And after this weekend, I really wanted to share it. I was sort of saving it for some time later in the year, but after 20 years of working in the ER, I have found it worth my time sometimes to give our listeners some personal touch, some experiences that might make you more likable, easy to work with, and efficient, an efficient NP or PA. Sometimes it's hard to know where we belong. And that next segment that we're going to talk about after this in regards to anaphylaxis case will also give you a little pointers here. But right now, I'm going to talk to you about how to navigate some tricky waters. So I'd like to just outline and talk about a typical day for me in the ER when I'm collaborating on a team with physicians so that my patients receive the best care and nobody gets hurt. And when I say that, it means no patients get hurt, no one's egos get bruised, and no one is fighting or delaying or obstructing or hindering any team process for the patient.
I think you're really being patient centric here, or you're going to be here in a few minutes. And I really like that. I think in the end, that's where, if we're having a hard day, that's where our mind should go is what is the best thing for the patient? And can we just all get on team patient and do that? Like Ken Millen has said before.
Yeah. So let's say I'm working the 10 to 10 shift. I get there at 10 a.m. I'm leaving at 10 p.m. that night. And I arrive ready to go. There are 30 people in the waiting room, and there are 5 traumas going on, and a new pod just opened up. So now there are 8 patients in the back waiting to be seen. No one has signed up for them. Well, this is what I do. I greet my coworkers. I talk to the staff. People are typically happy to see me. For those of you that have come to the boot camp, you also know my slits theory. And that's how I start to slice and dice patients through triage and in the back. I'm going to talk about that in a moment. But what's really important, and I got to tell you, this sets the tone for your whole day. When you show up there and it's busy, rolling your eyes, complaining, talking about how awful it is, really, it just, what's the point? Be a positive person. This is your job. You chose it. If you really hate your job, you hate the place you work in, don't just stay there because you're worried that you're going to lose your pension. That is the saddest excuse that I have ever heard for people that stay in a place that they hate. Only you are in control of your destiny. So I'll leave that soapbox for later. But back to slicing and dicing patients.
Yeah. So you know what? I'm going to, since you're vacating the soapbox, I'll go ahead and get on it. Cause like I used to work with a clinician, well, a staff member really, that every single shift, this person would walk out from a patient room and throw their hands up in the air and say, I quit. Like to a shift, this person said that every single time. And I just wanted to be like, go ahead and quit. Like, do you want me to like, no, please don't, like, no, like, you know, this is a really like, you're not making things better by that attitude. You know, I think that there is some value in commiserating sometimes. You know,
Mhm.
I think that people kind of, if you're a little bit too Pollyanna-ish, we're like, oh, like everything is awesome. You know, like there's this phrase like this, like toxic positivity, which I'm not really sold on, but like some folks are nowadays are like, oh, it's like you're almost being too positive. There's a line, right? There's a
Right.
line. And I think you're talking about walk the line and don't go too far the negativity and be dragging folks down that way.
Right. And again, there is time that you can spend to commiserate and say, you know what, today is just really a bad day. I'm not having a great day. But I always tell both my nurses that I train, my nurse practitioners and the PAs, when you're starting off talking about a history, when the attending says, "Would you like to tell me about your patients?" That's not the time to say like, yeah, I'll tell you. Joe is back again with his shit." You got to leave the subjective stuff and kind of like the stuff that might cause bias for the end of your presentation. So I like to have kind of just put all that, their complaint up front, then talk about their objective, their physical exam. And at the very end, say, "Hey, you know what? There's actually a mom at the bedside who's been asking me a lot of questions. So just FYI, when you go in the room, don't start off your presentation with the mom is crazy, So anyway,
Got it.
back to slicing and dicing.
Yeah. So you said like slits. Yeah, that really
Slits.
caught my eye here.
Mhm. So I like to take an inventory. I use my slits mnemonic, that's SLITS, to prioritize patients, especially when COVID is the chief complaint or on the differential. S is for subjective. What are these patients telling me right off the bat? L for listen to their lungs. Are they respiratory wise stable? I is for ill. Do they look ill? And T, what is the timing? Have they had this for years, minutes, hours? These are all the keys to the prioritization of these patients that saves me every day.
You told me before about other S words that go along with S for slits, and so you've talked about like suicidal, severe, sudden. I agree that when these things are used in the patient's description, then that should kind of catch your attention, or you should be asking about these things like how, is it a sudden onset, severe? There's ways to kind of ask them without asking them. That's kind of the art of taking a history here. But yeah, I like that slits thing. And so, like, just quickly, you mentioned COVID off the bat here. Are you having a lot more cases recently?
We
Is that
are.
that's the reason? Yeah.
Mhm.
I'm having more than I had been in the past few months. So, okay, just curious about that. Okay,
Yeah.
great. So slits.
Yeah. So then I eyeball all the rooms, whether I'm in triage, I eyeball the waiting room, or I eyeball the rooms of the patients that were all just placed there. And I listen for moaning, yelling, crying. I do listen for that. And then I sort of listen to the nursing chatter. I wave to my regulars and I take the time to take a mental note if they appear at baseline. I do acknowledge them. I do tell them that they're going to be seen today. And then I look at the ESI level of the patient and determine who needs to see a doctor next and who needs minor things I can quickly move so that the sick patients can come back to replace them. I repeat these steps several times during the shift and touch base with my colleagues in mini huddles throughout the day and attend any sign out. More on sign out and mini huddles later.
Okay, yeah. We know that sign outs and other transfers, whether it's transfers between nurses, transfers between shifts, transfers between ED to ICU or med surge, that's a big place where things can fall out and be missed. And you can have these, higher risk for sentinel events during those transition points. So yeah, that makes a lot of sense. ASAP, the American College of Emergency Physicians, touches on how important these events are and has some suggestions as far as how to do effective sign out with your staff to help, again, to help what? Patient care.
Yeah.
And in the end, that's what we're all here for. And that's the purpose of doing these, what may feel like kind of more onerous things to do. But in the end, it's for the health of the patient, the safety of the patient. And I know you're putting those in the liner notes on
Yeah,
twoview.fireside.fm.
you can also just Google safer sign out ASAP and it'll come right up if you want to use the
Yeah.
form like today and check it out and try it. So after I've seen a few people, the sickest ones first, I get the motors going. Let's just say that I have 2 chest pains in their 70s that are waiting and a few abdominal pains and then 2 lacerations and a potential fracture. I got that all recapped. I noticed the major important things about those super sick patients and possibly put in some orders and alert the doctor that I'm working with that maybe she could go to those rooms 1 and 2. I'll go repair these 2 lacerations. I put in a note and a few orders. And then one of my attendings says, "Oh, hey, maybe this person needs a chest x ray and I'll add it on." Or, "Did this person need a D dimer? What do you think?"
So just so I understand your setup here, so you mentioned you have this pod of 8 people. So is it you and a physician working that pod together? Like you both going to come on shift and that's your pod? Is that that works for you?
Yes, that's traditionally what we do, although there sometimes is another NP or PA and we kind of roll with it.
Nice. Okay. All right. Well, then, so you've got kind of like the game plan. And so you divide and conquer between you and the physician and maybe, like you said, another PA or NP. I think probably between these patients, you guys are passing each other in the halls. You're having conversations about these patients, updating each other, having little discussions. I think it's important just to keep things straight, especially when, like you said, you have two 7-year-olds with respiratory issues. I think it's important you start a note, put down some sort of a something about their history and physical that distinguishes them from the other patients you saw that day, just to keep things organized so that later on, when you're kind of like cleaning up, it's all kind of neat and tidy for you.
Yeah, creating a note as a reminder and a start time for when you began that patient care is super important.
Yeah.
I notice a lot of times people start that note and don't put anything. It really only takes about 60 seconds to write that short history. So why not do it? Um, I don't know. Sometimes I see people, NPs and PAs, they see 6, 7, 8 patients and they don't do a single note. And then I hear them cry, whine, complain that they have to stay late to finish their charts. I mean, if you're staffed appropriately, you don't need to carry the whole department. Why don't you keep up with the flow, but like work on your notes? Because then it's more commiserating at the end of the shift about how much you hate your job. Well, I got a chart too. So, anyway.
And I think it's just it's an efficiency thing. Like you think that by not charting immediately something,
Mhm.
I could be doing something else right now. Yeah, like you could, but on the back end, it's so much harder to like dig deep into your memory here to like, what was the deal with that patient? And was it the middle finger or the ring finger? And like
Mhm.
which joint was over? Like, I agree that 60 seconds it's just like going to sign out from EMS, right? Like the handoff. You go and you stop what you do and you go and you receive the EMS handoff, and that is a good investment in your time.
Yeah. Um, again, we as a team repeat these steps all day long together as a team. At no point am I intubating a patient by myself or discharging anyone without running it by the attending team. Oftentimes, we see patients together, we plan care, we talk to the patient, we let them know they are important, we involve specialists, we share the load. We know our jobs and we know how to do them well. Let's just say that one of my patients with a laceration as a kid and I want to PCARN them out, right? So head CT or no. I have that crucial conversation with the attending about imaging versus not imaging. And I use evidence based practice to make sure I am highlighting the plan of care appropriately and doing the right tests. So, yeah, I can repair the lack, but I'm also making sure that the patient and their family and the attending are all on the same page.
You mentioned that sometimes you have your, regulars. Some people call them, familiar faces or other maybe more derogatory things here. Let's say you've got that regular there and they've missed whatever chronic treatment they get, whether it's dialysis or methadone, and they like they can't get back in to get their regular treatment. How do you handle that?
Yeah, so there's also very unique cases that come in that you as the MP or PA can save the attending from having to see and deal with, unless of course there's something really crucial going on. In this particular case, someone coming in for their methadone without any new issues or concerning finding a problem, I think this patient can be seen by me and discharged to say, like my friend Nancy down the hall. And I've called her and I've said, hey, can you just leave the window open? My patient's coming back for their methadone dose. I relay the plan to the attending just to say, hey, Joe's here. He misses methadone, but we're kind of on target that I can get him there. Yeah, so the attending might swing by and say, hey, Joe, I see you're here today. Martha, it sounds like she's got your methadone. Want to get you out of here so you can just get your dose. Anything else you need? And Joe says, no, I just want my methadone. So works out well, saves a lot of time.
Yeah, I really think there's some value, and I think it's being realized by a lot of these, ASAP and other large EM kind of governing bodies, where it's kind of like they recognize the burden of these familiar faces and how there is harm in repeating the $1 million workup every single time for these patients. But what's hard on the clinician is that sometimes these patients are not low risk people. Like I'm thinking particularly of a patient that I used to know, um, COPD, late middle age, coming in with shortness of breath, occasionally some chest pain. I mean, that potentially could be a 3-hour plus workup if you're thinking about all the horrible things that could be going on there.
Yeah.
But what I did recently for a patient like that was I used some of the information from the chest pain evaluation and diagnosis guidelines we went over on a previous podcast. And I had kind of a shared decision making with the patient and the attending. And I said, listen, you're here for the same stuff. There's no change in your, chronic chest pain. You had a heart cath in the past 2 years. There's a warranty on that. Like we talk about, right? You're good for 2 years. We don't think you're going to have new ischemic, chest pain. As long as your pain is the same as it usually is. It is. Hey, great. Well, look, there's a value in just doing your breathing treatments for your COPD that we know you have, that this feels the exact same as usual, and we get you going. And we did that successfully, I think, in this patient. And the patient didn't get extra pokes. Our nursing staff didn't have to give the patient extra pokes and be occupied by that patient. The patient wanted to get their shortness of breath under control. Mission accomplished. And I think she got out of there with what she wanted, and it minimized the drain on our resources. In the end, the patient was served.
Yeah. Well, lastly, let's talk about this really critical, awful patient. Sometimes there's two types of NPs and PAs, ones that want to be involved in this critical patient, and other ones that say, oh, no, that's a critical patient. Like, I'm just going to go sit in my chair and like
Right.
look at Google. Right. So I'm totally like putting people in a pocket right here. There can be people in between. But basically, if there's a critical patient, you don't have to say, oh, the doctor's going to see that. If there's a patient needs intubation, lines, whatever, tubes, the physician can go in the room with you together. In this particular case, if it's a sick patient, I'll put an ultrasound guided line in, an IV line. The physician will be at the head of the bed running the code. We'll order meds. The nurses give the meds. And hey, maybe I could drop the NG tube and eventually put in a central line if needed. I mean, we run like a well-oiled machine. We work together. We discuss pros, cons, possible diagnoses, things we need to think about, catch each other. If we're making mistakes, we're going too slow, we're going too fast. And it's just about support so that the patient gets amazing care.
Yeah, it's interesting. I know that you're not bagging on the PAs or NPs who have a certain kind of niche, so to speak. I'll be honest. In my department, with the acuity mix we get, and the size of the department, and how we're staffed, when we get sick patients like that, we do it a little bit differently. The physician goes into that room and stays there and does all that. And we've talked before about how you don't feel like the NP or the PA should be running the department alone. And no, I don't think that's fair or feasible for an entire shift.
Yeah.
But when you have a critical patient like that, like oftentimes that's kind of what happens for us. Like the physician goes into that room and doesn't leave for, half an hour, and I am the traffic cop out there. And, kind of like you talk about, we work together. The relationship that we have, and it's not bagging on your approach, because your approach works, I think, for your acuity mix and your skill set, where you have, I feel like, more critical care skills than I do, and you're more comfortable with critical care medicine than I am, frankly. The physician and I have worked together for years, and he trusts me that he can just be in that room and he can have a laser focus on this one patient, and he knows that I've kind of got it. And he'll come out and we'll talk when he comes out. And in a way, that's helpful for him, because he can just focus and he doesn't have to worry about like, how's Mike doing out there? But I can,
how's Mike doing?
Yeah, hopefully he's okay while I drop this line
he's
here.
Not dead. All right. But honestly, it doesn't matter what your approach is, as long as it works for you. And this one sounds like it works for you. And I think that is the whole goal here of this conversation, is that we, as a team of nurse practitioners and PAs, get criticism for, a lot of things. But if you're effective where you are, and it's working, and you're safe, and you're used in a way that is beneficial, then keep doing that.
Yep.
The other lesson is, if you're working in a place that sucks, I don't want to hear it anymore from you. Go away. Take a break. I'm sorry. That's the hard truth. That's what I've done my entire career. I left a place I was at for 10 years and I loved it until I didn't. And I left. I lost my pension, but you know what? I am so much happier that I left that place. So that's that.
Yeah,
Mike,
we just talked about how we have different departments. You and I work in emergency medicine, and we teach at this boot camp. July coming up. Make your schedules here. But like we have both got different setups for our departments, and they work for us where we are at in our careers and our skill sets. And I think it's important that if you're stuck in a bad way in your department right now, and you think that this is a decision between emergency medicine and not emergency medicine, it's not like that. Like I could go to Martha's hospital and I could work in a higher acuity,
oh no, you don't want to come
hospital
here right now.
Well, I mean, or a similar hospital to Martha's, or Martha could come to my hospital and she could kind of take a break if she wanted to take a break from all the critical care skills, and she could do more just like, really, focusing on maybe lower acuity, but higher volume if she wants to do that. Like there are different places you can work at in the emergency medicine urgent care world. It's not just about leaving or staying necessarily.
Yeah. So
and
anyway,
in the end, oh yeah, go ahead.
No, in the end, I think that you gotta do what makes you happy. It sounds so cliche, but you really do. For me, when people say to me, Martha, I can't believe you're driving to San Francisco for the whole weekend and you're working a holiday and their nights, like, why? That sucks. I can't believe your job would do that to you. And I say to them, I chose that. Nobody tells me what to do. If anybody knows me personally, I only do what I want to do. If I didn't love it or enjoy it, I wouldn't go. So you need to find that for yourself. And again, I know people that do the same job as me at the same hospital and they hate their lives. So it's all about what works for you.
Yeah, my phrase is, you know what? I chose the thug life.
There
Okay.
you go.
I chose this hard because there's other kinds of hard out there that I don't like. I
Oh
like
yeah.
this hard, and I think I'm okay at this hard, doing this hard.
Yeah. Oh, this has been a good segment, but I think we should move on and talk
Yeah.
about the third segment here. And now I forget what we were going to talk about, Mike. I was feeling so sentimental about how much I love my job.
Well, good. That's good. That's really good. Well, so what I'll talk about is, that was strategy and mindset. This is tactics. Okay. These are things you can apply for your next shift. This kind of a talk. I gave that kind of a talk at the American Academy of Emergency Nurse Practitioners about a few weeks ago. And I wanted to share some of the tips that I gave out at that talk that I felt were most high yield, in a way that you can hear the rest of my talk, the rest of the tips for free. I'm going to talk 3 scenarios: the adult respiratory patient with possible pneumonia, the patient with a dislocated shoulder, and the patient with a migraine-like headache. All these things can sometimes take a long time to work through, work up, and discharge. Martha, how common would you say these patients are in your practice, those kind of scenarios?
I had them all yesterday and I remember them vividly.
Right, exactly. So these are common scenarios here. So scenario 1, a generally low risk adult patient with respiratory symptoms. You've adequately ruled out any other badness beyond some sort of an infectious process. And you're trying to decide between an upper respiratory infection and pneumonia. I feel like a lot of folks come to the ER nowadays with just this like subjective dyspnea. Like they're just like, I feel kind of short of breath. And you're like looking at them and they don't look short of breath at all. And you're like, well, objectively, your vital signs are good, but they're saying short of breath, and they checked in saying they're short of breath in their chief complaints. So you're like, all right, well, maybe they have pneumonia. I think a not uncommon practice is to take this patient and say, all right, we'll do a chest x-ray just to be sure. And if we see infiltrates or consolidation, we'll prescribe antibiotics. If we see nothing, we'll call it a URI and give it supportive care. Now, depending on how well staffed you are, how high your volume is, whether you're waiting for official radiology overreads or not, or do you just go ahead and read your chest x-rays, even just doing one chest x-ray is not necessarily a short process. Let me introduce you to the Heckerling clinical decision rule. Heckerling and colleagues published their rule in the Annals of Internal Medicine in 1990. This is not a super new thing. This was a prevalence study of 1,134 adult emergency department patients. So the setting matches ours. aren't, ICU patients. These aren't primary care patients. This was validated in 302 patients in multiple states. This is not, a tens of thousands of patient study, but it's not chopped liver either. The average age of the patients was in their mid 40s. So again, there's not super, necessarily like teenagers or super old people. It's a good mix. This is a 5-point clinical decision rule. Each of these 5 data points gives you 1 point. They're pretty straightforward. Martha, give us those points, please.
Yeah, so this is a temperature greater than 100 degrees Fahrenheit, a heart rate greater than 100 beats per minute, crackles on auscultation, decreased breath sounds, and the absence of asthma. So most of our patients already get 1 point for just not having asthma.
Right. So follow me here. Put your math hats on for a second. What Heckerling and colleagues figured was that having a score of 0 or 1 gave you a likelihood ratio of having pneumonia-like infiltrates on a chest x-ray of 0.12 and 0.2 respectively. So you were basically very unlikely to have pneumonia-like infiltrates on a chest x-ray if you had a 0 or a 1 for this score. They kind of figured the pretest probability of an ED patient to be potentially as high as 15% of having pneumonia-like infiltrates. That might be higher than your emergency department, depending on your acuity level that you usually get. But basically, they said, all right, we'll say 15% likelihood. So they multiplied that percentage by the likelihood ratios of 0.12 and 0.2 that they determined with their study. And they figured, if you do the math there, you've got about a 2 to 3% chance of having pneumonia-like infiltrates on a chest x-ray if you had a 0 or a 1 on this Heckerling decision rule. That's pretty low. That's how low the likelihood is of a PE when you've got a low risk by Wells score and a negative per criteria. For me personally, if that number is good enough to rule out a PE, it's good enough to rule out pneumonia.
Well, so in the end, we know that x-rays don't catch all pneumonias anyway. And there's a lot of subjectivity in a chest radiology interpretation. I think it's worth considering using this rule and maybe running it your own experiment if you want. I'm a big advocate for calling patients back, as you know, after they've left the ED. You can always keep contact info for these patients, call them in a few days, see how they're doing. But again, personally, if this person is low risk for crashing and burning, I'm okay with discharging and seeing how this goes. There's always a chance they get worse. Just make sure the possibility is known to the patient like you always do, and tell them when and where and how to follow up.
Yeah, I think I love that. Okay, so scenario 2 is shoulder reductions. This can be a pretty time-consuming and intensive process. If you're doing like a conscious sedation, then you got to watch them to recover from the sedation. As we know, there's a lot of different ways to skin the shoulder reduction cat. Consider using the Davos or the Spazo techniques. So these are techniques for shoulder reduction that don't require conscious sedation. So let's talk about them real quick. So the first one, the Davos, by the way, these are both for anterior shoulder dislocations, for kind of uncomplicated shoulder dislocations, right? So like not a fracture dislocation and not in someone who maybe is having something more serious, like another really significant comorbid condition, and I'll talk more about that in a second here. So let's talk the Davos technique first. The authors of the paper that we're going to put in our show notes, they retrospectively, looking back, evaluated 100 patients who had an anterior shoulder dislocation, and they described this new technique. So again, put on your kind of imagination hats and visualize this patient who is sitting on the stretcher in front of you. And let's say the patient has their left shoulder out. So you flex the same side knee. So the patient sitting on the stretcher, you flex the same side knee to 90 degrees, foot goes flat on the bed surface. Next, they take their fingers, they interlock their fingers and put them on the other side of their shin, so anterior to their shin. Then patient gently leans backward with the neck hyperextended. So I'll usually tell patients, hey, I want you to try to look behind, like look over your head behind you. Look back that way until the arms are fully extended. So now you have, the patient is putting traction on themselves, okay? The patient also rolls or shrugs their shoulders anteriorly to help facilitate the reduction here. So the reported success rate for this process, about 60%, but as high as 85% in certain kinds of anterior dislocations and in patients under 40 years of age. Those are pretty, like 85% reduce without conscious sedation and the patient can just go. Like, that's worth a try for me, in my opinion. Now, there are some disclaimers here in the study. About half of the patients who failed a reduction were patients who had psychiatric problems or dementia. And so, like, that's where I've had this process fail sometimes, is where a patient had comorbid psychiatric issues. They were not really interested in trying this technique without hardcore anesthesia on board, and so really the patient has to cooperate with this technique. I also had a problem with a patient, if you can imagine, sitting on the stretcher, knee flex to 90, if they've got a pretty large abdomen, whether it's from pregnancy or from obesity, whatever, that can kind of mechanically get in the way. So those are the places where I've had this one kind of fail. So this is a 2018 publication. And I'm going to go back. This actually was a little bit previously to that. But then they went and took this technique and compared it to a different technique, the Paso method for shoulder reduction. Okay, this is another non-traumatic clinician-controlled technique, a little more easier to visualize. So now your patient is lying flat on their back on the stretcher, and you take their arm and you just gently, slowly lift it vertically by grasping the wrist. Gentle traction being applied while the arm is externally rotated gently. So you're pulling up and you're rotating the arm externally. Reported success rate, 67% in prospective studies, even as high as 90% in retrospective studies. Okay. And so I've had success in both of these techniques with, I pre-medicated, like I gave the patient, some, opioids, PO. I even gave him like a shot of, lorazepam to kind of relax him a little bit. And then I was able to like dislocate, relocate, not dislocate here. And, it was kind of like one of the more like reassuring things when like I did this for a patient one time in a busy shift, and I went back to the attending and I was like, hey, patient room 1, put their shoulder back in. They're ready to go. I think we're just going to do a post reduction x-ray. And he's like, I had no idea there was a dislocated shoulder in room 1. So like these are great techniques that I think are worthwhile to use on a busy shift. I'm going to save the migraine stuff. I'm going to use that as a little bit of a teaser, honestly. Okay. So if you want to hear the migraine tip, then hey, come listen to this talk I'm going to do. Facebook is starting some sort of new Facebook classes feature where people can teach classes using Facebook. And I was, selected for some reason to join the instructor program to do like some pilot testing. I haven't hashed out the time or details quite yet, but I'll be doing this class and probably a class on how to do more advanced like Paxlovid prescribing, because as you know about Paxlovid, there's a lot of medication interactions. And so I had a really interesting case I worked with the other day, and I thought it would serve as a nice case study on, what to do when someone has polypharmacy and whether they are good candidates or not for Paxlovid. We'll talk kind of some of the more recent Paxlovid concerns as well. So a couple classes coming up. I'll put out more details on my social. Worst case, you just email us. Our email address is always 2viewcast@gmail.com. That's the number 2, viewcast@gmail.com if you hate social media. If not, look me up. I'm Mike Sharma on Facebook. I'm on a lot of the PA and NP groups. Twitter is @Michael Sharma, and Instagram is @Michael Sharma PAC. Just like friend me or something, and I'll post when I'm going to do these classes, probably sometime in the June month here.
Yeah, you should do the migraine one. That would be great.
I will. Yeah, I'll talk about that. I thought there was a lot of good information on like what is the best like intramuscular shot, and maybe there's other techniques we can do these kind of like nerve ganglion blocks and stuff too. So we'll talk about ways to work on migraines without putting somebody in a room with an IV and an hour wait time and that sort of thing.
All right, Mike. So let's wrap this up today. This is a quickie case that I think is kind of cool. And so I'm just going to quickly run through it. And this case kind of demonstrates not only experience taking care of patients, but a true understanding of anaphylaxis. Okay. So for this segment, we're going to talk to you about anaphylaxis. And the reason why I wanted to bring it up is because I had this interesting case of a 50-year-old man who was stung by a bee on his right eyelid,
Ugh.
on the lid itself. He was stung around noon, and then he came to the emergency department around 6 p.m. after taking 2 tablets, 25 milligrams of Benadryl. And the reason why he ended up coming to the emergency department is because he was concerned about the amount of swelling in his face, right? That was his main thing.
Sure.
Why did you end up coming 6 hours later? It wasn't the pain. It wasn't really anything other than this swelling on the face. He said in the past he had gotten, quote, an injection before, but he didn't think it was epinephrine. So we went through all those questions and he said, when I said the words prednisone or steroid, he was like, yes, it was a steroid shot. I know that. And he had never been intubated or had any swelling of his lips, his tongue, or trouble breathing or any other respiratory complaint after a bee sting. This immediately made me think about what is mild, moderate, or severe allergic reactions from a bite or sting? Or
Yeah,
is it anaphylaxis?
right, exactly. Yeah, because it's an important thing to decide early on what you're going to do. Anaphylaxis causes the immune system to just flood the patient's body with chemicals that can go cause the patient to go into shock. Your blood pressure drops, your airway narrows, your breathing is obstructed here. Some signs and symptoms you may see are a rapid, weak pulse. Maybe you see a skin rash, generalized, or maybe you have the patient having some abdominal pain and nausea and vomiting. True anaphylaxis is sometimes hard to recognize, especially if you've got kind of a later onset presentation, or if there have been medications that have been used since the exposure. For people that have a history of epi or EpiPens, epinephrine in the hospital, you consider you're probably going down that path. They're a little bit higher risk individuals.
Yeah, so although anaphylaxis can be multifactorial and multisystematic, the key elements of knowing when to give epinephrine versus not is to consider the involvement of the tongue, lips, or throat. Respiratory compromise may be mild or severe at first. Could just be like, scratchy throats, but sometimes pulling the trigger early on epi is necessary and life-saving.
And it's so hard, right? Because I had a patient that had a pediatric patient, real big swelling of the lips. And it's like, lips, airway. Am I going to have to put epi on this kid? But it's like everything else was so reassuring. And we made the hard decision to not give epi that time. And thankfully that time we were right, but I could totally see this going the other direction, when like the patient progresses and it's like, now you're regretting not giving epi earlier. And so it's not always a slam dunk, and it can really be a tricky diagnosis to get.
It's like, I want to get that tattoo, like as an ER worker, no regrets.
Yeah,
right?
exactly. No, yeah, exactly.
So simple urticaria or localized swelling may be a sign of allergic reaction, but not necessarily anaphylaxis. So when I think about the signs of anaphylaxis, I like to break it down into systems. Like I said, skin, central nervous system, cardiovascular, GI, and airway. So about 80 to 90% of all allergic reactions of sorts will have some kind of hive, urticaria, itching, flushing skin, or any rotation of those things around the body. The other some 10% may just have simple localized irritation that will subside on its own, unless it's the face. And that responds, I would like to say, aggressively. For the unlucky, about 30% of people with severe allergic reaction will have cardiovascular events like chest pain, hypotension, tachycardia, weak peripheral pulses, kind of that shocky looking presentation. And occasionally patients will develop these GI issues like nausea, abdominal pain, vomiting, or diarrhea.
Yeah, there's a couple scary presentations. One scary presentation is the airway compromise, of course, right? They've got tightness and swelling of the throat. They've got this kind of hoarse voice, scratchy throat, trouble breathing or wheezing. I also get concerned when I see vital sign abnormalities, like that kind of widened pulse pressure with a really like an outsized low diastolic compared to their systolic. or, their heart rate's like super high, I'm worried about those situations for sure.
Yeah. And we've all had those patients that get epi right through their genes. So let's go back to talking about this guy with the bee sting to his upper eyelid. This was definitely a really scary presentation at first. But after about an hour or two of observation, and since it was almost 8 hours after his initial sting, he was classified into the more mild or moderate reaction, not anaphylaxis. The fact that he was stung on his eyelid was precarious and distracting because the skin is very thin over the eyelid and very sensitive. And like I said, the face is aggressive. It responds aggressively to irritation, bites, stings, trauma. So it scarily swells and looks bad, sometimes worse than it really is. Swelling and periorbital edema can occur simply from the actual trauma from the sting around the area that might concern the practitioner for anaphylaxis. But given the severity of the swelling here, this guy deserves some observation, which we did. In the case of this patient, he had no respiratory compromise and wasn't necessarily a candidate for epinephrine, although I was thinking about it.
Yeah, I think that's fair to be considering it for sure, and maybe documenting, hey, I didn't give epi, in real time because of this or that reassuring factor. Yeah, I'm forever telling trauma patients who get hit in the forehead, right, or have like a big cut on their face, hey, look, you're going to wake up tomorrow morning and you might not be able to open your eye underneath that wound. Don't freak out as long as you otherwise feel good. Yes, I'm always telling folks about how loosey-goosey that tissue is underneath the eye. I love that you're considering that anatomic issue here. Traditionally, we've talked on previous episodes about how to treat urticaria, how to treat allergic reactions. And so there's a place for your histamine 2 receptor inhibitors, like your tidine medications, famotidine, cimetidine. You've got steroids to consider, whether it's prednisone or methylprednisolone, and then some sort of like an H1 antihistamine. Benadryl is kind of like the like traditional one, but we talked, I think, pretty compellingly in previous episodes about how you can do Claritin, you can do loratadine, you can do fexofenadine, you can do some of these non-sedating antihistamines, and you can get some good relief from allergy as well. Okay, this is different than if this patient has like angioedema. So like, let's say it's a beta blocker, or they have one of these weird, familial angioedema things.
Mhm.
That has to do with bradykinin, and that's not affected by allergic issues, even though that's kind of like the knee-jerk reaction. Give this person Benadryl and steroids, right? Like that's a wholly different process. We're not covering that today. We're focusing on patient stung by bee, allergic reaction from that known exposure.
Right. So this triad of medications that you're giving, you're giving the Pepcid, the prednisone, and some Benadryl. Those are all fine. And then there's a lot of controversy in studies that talk about treatment times. They're variable. Some people do 3 days, some people do 5, some people do 7, some people do a taper. There's just really not great evidence on tapering. So I really have done away with that. A good rule of thumb is to prescribe the medications for at least 5 days, and doing a taper isn't indicated. So in this particular case, the patient got Benadryl, Pepcid, and 40 milligrams of prednisone in house. He was prescribed the same for the next 5 days. He was given an EpiPen in case he developed any kind of airway compromise. And a really nice clinical pearl here is to divide the prednisone into 20 milligrams BID instead of a whopping dose of 40 just before bed. That can cause anxiety and insomnia. I often tell patients to take the Benadryl along with the prednisone at bedtime. What I really wanted to talk about is the administration of epinephrine in this patient, right? So mild, moderate symptoms of allergic reactions, not necessarily anaphylaxis. Epi is not without side effects, as we know, on the central nervous system, and it can be uncomfortable for patients, causing more issues and discomfort than their actual problem. So we really don't want to pull the trigger on that epi unless we really are certain that we should. Is it terrible if you do and it wasn't indicated? Well, you'll never really know, right? Because the patient will get better. They'll have relief of some of their symptoms, right? The best overall approach to allergic reaction for patients that present to the emergency department is observation. Yes, I said it. Hang on to these patients. They are the ones we want to hang on to, and don't feel bad about it.
Yeah, I kind of feel like I'm contradicting myself talking about like how to get patients out of the emergency department. But exactly, like this is what I think the best thing. And not even necessarily the medications are more important. The observations are more important. Let's follow this patient over the next half an hour. That's what we did with this person that I took care of who had big lip swelling, and I was concerned about what was going on with them. I just kind of watched them and they didn't progress. And we discharged them with pretty much exactly the medication regimen that you described here. Okay. For the mild to moderate allergy sufferer here, Benadryl, or some sort of other antihistamine. I'm a big fan of other kinds, to be honest. Some sort of steroid, consider that. And then the Pepcid or the H2 blocker is probably going to be enough, frankly, to control this mild to moderate allergy reaction. If the patient decompensates in front of you, whether it's vital signs or addition of new other symptoms in different body symptoms, or appears to have a serious respiratory compromise, then epi. Epi is your first line therapy. Don't think twice when it's something that severe. Just go ahead and give it. But don't be fooled by these facial stings, especially to the loose tissues around the eye that are localized reactions that don't involve the lips, tongue, or throat. Localized irritation in those areas can cause real bad swelling, but they're not necessarily candidates for epinephrine because of that swelling.
So we're going to post an article from the AAFP in regards to managing these patients in our liner notes, which is a really good summary. In this particular case, just to close the loop, the patient did not present with clear anaphylaxis, so we observed him for several hours in the emergency department. He left several times to eat, smoke, and make phone calls, but always returned to the emergency department where I laid eyes on him. I opened his mouth and I looked in there. I listened to his lungs, and we had an agreement. So you might find it very strange that this is how I take care of patients in my emergency department, right? This sounds horrible. But for my particular area of work at San Francisco General, the patients come first. So that means they come and go as they please, regardless of whether we skip their name or can't find them. In a perfect world, these patients would be in a room on a monitor where a nurse observes them every, 15, 30, 60 minutes. In this particular case, patient got better. I saw him eating, drinking, and smoking, and he was discharged home safely.
I really need to come and shadow you on a shift at San Fran General someday. It just sounds like
I love
Mars.
that place. I love it. It's difficult work. And yeah, and like I said, it was a really rough weekend, but I still love it.
Yeah. Well, there you go. In summary, localized swelling to the face or the neck from a sting can be difficult to distinguish from a localized reaction versus a systemic anaphylactic reaction. Our suggestion, as much as we're talking about being aggressive and efficient and dispose patients quickly, these ones, spend time with them, look at them multiple times, check in on them frequently, document your, frequent times when you check on them and how they're coming along. It's okay to go ahead and give that, at least you give the antihistamine and the H2 blocker. Steroids, like you mentioned, people feel weird on steroids, and looking at some of these recent guidelines, I'm kind of pulling back on my steroids. Like, another way to consider, in my opinion, is you give them directions for hydrocortisone cream, right? Local application of hydrocortisone cream, H1 blocker, H2 blocker, and I'm prescribing steroids. And if you're not clearly getting better after a couple of days, yeah, you go ahead and take the steroids. But otherwise, you don't worry about the steroids. Because I've gotten patients who have bounced back. Like you said, they feel terrible on the steroids. They come on back. Okay. In the end, epi, if there's respiratory compromise, if that's mandatory as the number one treatment, there's only one for anaphylaxis. It's epinephrine. Okay. You want to avoid the intubation in this patient with respiratory compromise and anaphylaxis.
Yeah. So last pearl, Mike, this is the one that I find very key. And the nurses sometimes look at me funny, like, why? Well, I work in triage a lot and anaphylaxis occurs. And sometimes it's hard to draw up the epi. You pull it and then you pull down the pants. Like, in a pinch, crack the code card, grab your epi pen and put it right through those jeans. Honestly, save you time and airway. And that is key.
Yeah, that's worth investing in there.
Yeah. It's not cute, but it works.
Yeah, look, man, that should be in bright lights on the outside of every emergency department. Emergency department, it's not cute, but it works. Okay. Well, this shows something sweet is a personal one for me and Martha. We both happen to have two loved ones go to the emergency department and get admitted to the hospital, coincidentally, very same day. We're both happy to report that they were able to be safely discharged and they're recovering at home right now.
Yeah. Weird thing is that they were also, so they were admitted on the same day and they were discharged on the same day. And we both talked, and I was like, wow, what a coincidence.
Different towns, right? Different hospitals. It wasn't like
Yeah,
that
not room
coincidental.
together.
Yeah, exactly. They happen to come in at the very same time. No, it's nothing like that. Okay. So number one, we're so happy you guys are okay. Number two, a big shout out to all the caregivers at the hospitals that took care of our loved ones. For me, it's a thank you to the fine folks at the Sierra campus of the hospitals of Providence in El Paso, Texas, especially Dr. Madhu Achalla.
And for me, huge thank you to Dr. Brendon Carmondy, who is the Assistant Director of the Emergency Department at Suburban Hospital in Maryland. I'm so grateful for you and your team and the people who helped.
Thanks, folks. Thanks to the physicians. Thanks to the nurses, the PAs, the NPs that were all involved in the care of our loved ones. Well, let's talk about our trivia question. We've talked about it. Boot camp's coming up in July. You got the advanced camp in August, December's. We're running it back for our boot camp course. Again, the original one. You win this trivia contest. You can come join us in Las Vegas this July. You get 20% off of a boot camp course.
Oh, actually, Mike,
yeah?
I have been told by Rick that we may give one more free course. So this one, the winner of this one gets a free course.
Whoa,
free course.
That's a huge value. And that can also apply if you don't want to hang out with us, a self-study course, or if you do want to hang out with us, just not in Vegas, do the acute care series course, emergency medicine and acute care. That's at a couple of cool locations every year throughout the country here. A free course. Okay, that's awesome.
Yeah. So here is the question from last month and the answer. We asked, we've been following Kenny Mintz, a friend to the show and someone we've had on show episode 14. He's walking across America to raise funds for pancreatic cancer and the Johnny Mac Soldiers Fund and Operation Resiliency. His 3,000-mile journey began on April 1st, 2022 at the Lincoln Memorial. And it's going to end in NC. Where is it ending?
In Encinitas? Is that right,
okay.
California? I know it's over there in your neck of the woods.
Yes. And you can follow him at Kenny Walks Across America on Facebook and Instagram, or his Facebook group, Kenny Walks Across America group. So our question basically was, name some places that Kenny has stopped and 2 key facts about those places. Well, let me tell you, we got a lot of answers on that one. Kenny is actually on day 49. And he was recently in Indiana. He had some really nice luck there, got some travelers with him. He was given a hotel, some hotel.com stuff, and people really just supporting him. He was also recently in Ohio and Kentucky, and he's making his way all the way across the country. So nice work, Kenny. Can't wait to see you. The winner was Jesslyn Haynes from Seattle, Washington. So we're going to make sure that Jesslyn gets what she deserves.
That sounded really ominous, but we promise it's something good. Okay. So yeah, don't worry about Jesslyn. All right. So this month's question, which of Newton's laws states that for every action, there is an equal and opposite to reaction? And in what year did Newton die? All right. So we're going back to our high school physics here. And please go ahead and email us your response at 2viewcast@gmail.com. That's number 2viewcast@gmail.com. First respondent gets a free boot camp course.
Yeah. And Mike, I put that question in here for a couple of reasons. Everything you do, something's going to happen. Everything you say, something's going to happen. Every bad attitude or good attitude, something's going to happen from that. So yes, we're talking about physics laws here, but if you want to theoretically apply this to some psychological stuff, that's kind of why I threw it in. But the year in which he died is going to be a little interesting of an answer. So we're ending. That's it for this month. For more information about us and our faculty, visit our website featuring all our upcoming courses at www.ccme.org, and consider coming to see us in July or any other time this year, post-vaccine, of course. So next boot camp, as we said, July 26th through 27th for the pre-course pharm and ultrasound courses. The main course is July 28th through the 31st. August is our advanced boot camp course, where we'll have that EKG and imaging boot camp, in which I will be attending. Very excited about that. And then again, we have our regular boot camp course in December. Please check out all of our self-study courses, farm course, heart course, EKG course, everything at www.ccme.org.
Thank you for listening to this episode of The Two View. You can, and please do subscribe and rate us on Apple iTunes podcasts, Google Podcasts, and Spotify. Search for Two View Emergency. That's the number 2 View Emergency, and it'll come right up. And, I'm just going to audible this in here. We're going to start putting in some reviews from people who do review us here. We're going to read them on air. You can hear your name on the air. It's been really reassuring to me to hear that people are enjoying the podcast and are taking the time to rate us. It really does help us climb the charts so that other clinicians can get some of that Two View goodness you're getting right now. If you like YouTube and want to see the video blog instead, I'm wearing a fetching Hawaiian shirt here. Martha's got a nice, blouse on. If you want to see that, go ahead and search for Center for Medical Education. You can catch the video version. Don't forget our website where you can go next level on any of our topics from any of our episodes, including all the papers and sites we referred to. That's twoview.fireside.fm. Our audio and video engineers are Reki Bukata and Dave Pett. Show notes are by Meg Dipple.
Thank you for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today on The Two View. Have a good day and a great shift.
And enjoy your nap, Martha.
Peace out.